Hey everyone, and welcome to this high-yield medical explainer on the tibia. Whether you're an MBBS student gearing up for board exams, a physiotherapy student, or just someone fascinated by human biomechanics, you are in the right place. We're going to do a definitive, systems-based review of the primary weight-bearing bone of the lower leg. So, let's just jump right into this incredible piece of skeletal architecture.
Our agenda today follows a really logical path. We'll start with architecture and side determination, then move through the osteology of the proximal, shaft, and distal regions. Next, we map out the musculature and ligaments, dive into vascularity and ossification, and finally, we'll tie it all together with clinical pathology.
All right, Section 1, Architecture and Side Determination.
So, positioned medially as the larger bone of your lower leg, the tibia has a massive job. It acts as the sole transmitter of body weight straight from your knee down to your ankle. Think of the femur transferring the absolute entire weight of your body onto the tibia, which then just drives that force directly down into the talus bone of the foot. The fibula, sitting out there on the lateral side, it's essentially just along for the ride when it comes to bearing weight. The tibia is the true, vital lever for the muscles of the leg and foot.
Now, when you're staring down a bone in your practical exam, absolute side determination relies on three non-negotiable cues. First, look at the top. That prominent tibial tuberosity absolutely must point anteriorly or forward. Second, run your finger down the shaft. The sharp anterior border, your shin bone, curves right down the front. And third, look at the bottom. The medial malleolus has to project downward on the medial side. Align those three landmarks, and you are going to perfectly determine right from left every single time. No guessing required.
Section 2, Osteology, Proximal, Shaft, and Distal. The proximal end is heavily expanded, creating this robust weight-bearing platform for the knee. And it's totally asymmetrical. The medial condyle is much larger, it's got an oval footprint, and the articular surface is distinctly concave. Why? Well, it needs to securely cradle the larger, C-shaped medial meniscus. The lateral condyle, on the other hand, is smaller, nearly circular, and flat or even slightly convex, because it supports the much more mobile lateral meniscus. This physical mismatch is exactly what dictates the complex biomechanics of knee rotation. As we move down from the knee, the shaft of the tibia forms a really distinct triangular cross-section. It's basically built around a rule of threes. You've got three borders: the sharp anterior shin crest, which is totally exposed and subcutaneous, the medial border running down to the malleolus, and the sharp lateral interosseous crest. These borders frame three broad surfaces: the medial, lateral, and posterior flats. Honestly, this triangular prism shake is just a masterclass in structural engineering. It maximizes strength against bending forces while keeping the bone's mass as low as possible.
Down at the distal end, the tibia essentially forms the structural roof of the ankle mortise. The inferior articular surface is remarkably smooth and saddle-shaped, perfectly ready to articulate with the talus. But I want you to pay special attention to the lateral side. There's a distinct triangular depression there called the fibular notch. This notch is absolutely crucial. It forms the rigid distal tibiofibular joint, essentially locking the fibula into place and stabilizing the entire ankle ring against some pretty massive rotational forces.
Moving right along to Section 3, Musculature and Ligaments.
When we map out the soft tissue attachments, isolating muscle origins in red, insertions in blue, and ligaments in green, it instantly reveals the tibia as so much more than just a support column. It's a massive anchoring pillar for the entire lower limb. Just visualizing this, you can really appreciate how incredibly crowded the proximal and posterior surfaces are, especially when you compare them to the completely bare, subcutaneous anteromedial face of the bone.
There's a fascinating functional divide across the shaft, too. The medial surface acts as a major insertion zone, most notably for the pes internus. That's a confluence of tendons that dynamically stabilize the medial side of the knee. In stark contrast, the vast upper two-thirds of the lateral surface serves as a massive red origin zone. This is the launching pad for the tibialis anterior, which is the primary muscle responsible for pulling your foot upward, driving ankle dorsiflexion every time you take a step. Spinning the bone around to the posterior surface, the entire architecture is completely dominated by the soleal line. This prominent oblique ridge sets the upper boundary for the massive soleus muscle. Just above this line, the popliteus muscle inserts to literally unlock your knee joint. Below that intersecting ridge, the remaining posterior surface is strictly divided into medial and lateral areas, and those firmly anchor the deep flexor compartment, specifically the flexor digitorum longus and the tibialis posterior.
Section 4, Vascular Supply and Ossification. So how does this massive bone stay alive? The primary metabolic driver is the nutrient artery, and there's a strict, really fascinating downward directionality to this vessel. You might remember the classic anatomical mnemonic, "To the elbow I go, from the knee I flee." Because the most actively growing end of the tibia is up near the knee joint, the nutrient foramen is deliberately directed downward, pointing away from the knee. This internal supply is then supplemented by dense periosteal vessels on the outside, feeding the outer third of the hard cortical bone.
As for ossification, it proceeds in a very predictable linear timeline. The primary ossification center appears right in the middle of the shaft around the 7th fetal week. A secondary center for the upper end pops up right around birth, which, by the way, is a unique medical legal sign of a full-term fetus. A third center for the lower end appears by year 1. Then, the bone just continues to grow until fusion is completely finished, usually between 15 and 19 years of age.
Finally, Section 5, Clinical Pathology and our Active Recall Review.
Let's apply this structural knowledge. Looking first at biomechanical overuse, we frequently see Osgood-Schlatter disease. This presents as a severe, really painful traction apophysis right at the insertion site of the patellar ligament, right on the tibial tuberosity. Because the quadriceps are exerting massive repetitive extension forces on a tuberosity that hasn't fully fused yet, it becomes highly inflamed. You'll see this all the time in highly active, growing adolescents who are constantly running and jumping.
Now, when we shift from overuse to acute, high-impact trauma, the location of the fracture really dictates the clinical nightmare you're about to face. Think about lower third shaft fractures. This specific distal zone is incredibly prone to delayed union or outright non-union. Why? Because, as we saw a minute ago, it severely lacks a robust muscular envelope to protect it, and it relies on a highly precarious, distant blood supply. A break here often completely severs that downward flowing nutrient artery, leaving the bone absolutely starved of the resources it needs to heal.
All right, before we wrap up, let's pause for some rapid active recall. Let's test that exam readiness. Based on what we just covered about the medial compartment, can you name the 3 specific muscles that merge to form the pes anserinus? Take a second to think about it.
Got it? The correct answer is the sartorius, gracilis, and semitendinosus. Remember, these 3 long muscles cross the medial aspect of the knee and insert together on the medial surface of the proximal tibia, acting as crucial dynamic stabilizers. If you are prepping for your vivas, drill that triad into your memory.
Let's try one more high-yield question. Picture the superior articular surface of the tibia in your mind. From strictly anterior to posterior, what exact structures anchor into the anterior intercondylar area of the knee? Give it a thought. Okay, the precise exam-perfect order is, first, the anterior horn of the medial meniscus, followed immediately by the anterior cruciate ligament, or ACL, and finally the anterior horn of the lateral meniscus. Visualizing this exact spatial arrangement is absolutely essential for understanding knee joint injuries and reading those tricky MRI scans.
To pull all of these disparate systems together, you really want to synthesize the physical osteology, the dynamic musculature, and that critical vascular system. Seeing how all of those directly inform the clinical pathology and traumatic fractures gives you a unified, holistic picture. This is exactly how you want to structure your anatomical knowledge moving forward: interconnected, practical, and highly clinically relevant.
As we finish up this explainer, I want to leave you with a real-world scenario to carry on to the wards. Consider this. Now that you deeply understand the tibia's precarious downward-flowing distal blood supply and its distinct lack of a distal muscular envelope, how will that fundamentally change the way you approach, stabilize, and manage lower leg fractures when you're in the emergency department? Keep that clinical application in mind.